Good evening, everyone, and welcome to this panel discussion on ethical issues in dementia care, which is being hosted as a result of September being Dementia Awareness Month, and the 21st of September, of course, being celebrated as World Alzheimer's Day. I'm Dr. Avinash de Sousa. I am, of course, a part of the International Chair of Bioethics program. Apart from that, I'm a consultant psychiatrist from Mumbai and the associate editor of the Global Bioethics Inquiry. And I'm here today to be your moderator for this panel discussion on ethical issues. We will be asking the panelists a series of questions. We hope that they would keep their answers short, sweet, precise, so that we have as much time as possible for more questions. If anyone from the audience wishes to ask anything, please type it in the chat box. Keep yourself mute at all times, and we will answer whatever questions come in the chat box as the panel goes along. It's now my proud privilege to introduce our panel for today. I start, of course, with the lady first. And our lady for the evening is Mrs. Vidya Shenoy. She is an integrated dementia care specialist and also specializes in yoga for the elderly. She is the current secretary of the National Secretary of the Alzheimer's Related Disorders Society of India, and also is the secretary of the Alzheimer's Related Disorders Society Mumbai chapter, where I am working with her as the treasurer. So, welcome, ma'am, for today's seminar. Um, my second panelist is Dr. Sujoy Mukherjee, who is a consultant psychiatrist working in old age and the older people serviced at the West London NHS Trust, Elms Lodge, Greenford. He's also the General Secretary and Board Member of the European Association of Geriatric Psychiatry and an Executive Committee member of the Faculty of Old Age Psychiatry, that is from the Royal College of Psychiatrists. And Sir has, of course, done his master's and his post-graduation from India and then moved to the UK. We're very happy to have you here, sir, today evening. My third panelist is Dr. Shabir Amanullah, who is the Chief of Psychiatry at Woodstock Hospital, Ontario, Canada. He's the president currently of the Canadian Academy of Geriatric Psychiatry and the chair of the Indo-Canadian Psychiatry Association. And he's also the president of the Oxford County Medical Society. Of course, he has won numerous awards. Apart from geriatrics and dementia care, he also works with older adults and adults with autism. Sir, again, it's a privilege and a pleasure to have you with us here today. Lastly, our fourth panelist for the day is Professor Dr. Russell D'Souza. Professor Dr. Russell D'Souza is from Melbourne, Australia, and he is the head of education of the International Chair of Bioethics, which was formerly the UNESCO Chair in Bioethics, Haifa. Sir has been the Director Asia Pacific of the UNESCO Chair in Bioethics, Haifa previously. He's also the Dean of the International Institute of Organizational Psychological Medicine and the Chief Editor of the journal Global Bioethics Inquiry. And last time we had done a one-on-one conversation with Sir on World Dementia Day. And today we're doing this panel under the auspices of the Dementia Awareness Month. So thank you, sir, for doing this with us. We have an entire panel, one from India, one from UK, one from Canada, and one from Australia. So we'll get a varied perspective with regard to various facets of dementia care. And I will start with Dr. Shabir first and then come to Dr. Russell and Dr. Sujoy. Sir, in a country like Canada, where you work, where geriatric care is pretty specialized and there are specialized services available, if I would ask you, I mean, give us a brief about maybe a gist about dementia care services and any one or two major ethical issues that you all face over there.
Good morning, everybody. Good evening to those in India, and probably good afternoon to Sujay. It truly is an honor to be on this panel, and Avinash is always a very good moderator. We meet in very interesting times, obviously, but also times that have made it so easy for us to connect with one another and share knowledge. I'm very privileged to actually have worked in India. I have worked in England, and now I've moved to Canada. And I've worked across different parts of Canada. One of the key things whenever you work in any nation is to look at a cross-section of how things work or don't work necessarily in different parts of a country. Now, in Canada, as much as we feel that Canada is specialized, this term is often very loosely used, the term specialized. Because, for example, I can say a country is rich. The United States is rich, but if you go to the Bronx, you go to the US, many areas have absolute abject poverty. So the point is, when we say specialized services, we have pockets of incredibly specialized services, just like in Bombay. You can go down to fabulous services, and then you have general areas where you don't have it. So given the size and breadth of Canada, the second largest country in the world, we have such a massive geographical area to cover. The areas where we don't have specialized services, we have very ordinary, mediocre services. So when I travel across and I look at the dementia services available, centers like University of Toronto, in Toronto, London, Ontario, there are some key areas where you have phenomenal levels of service. Everything from very hardcore biological intervention, co-opted in with, you have the psychological services that are very, very high end. Memory, they've incorporated things like yoga now, they have used Tai Chi. Very nice to see how they've integrated different areas, but it's still not easily available to many other places. The pandemic brought a very interesting thing to the fore. It actually forced people to recognize that we have to change the way we practice, and we cannot rely on individuals itself to travel and go and provide the service, which is why this is such a blessing. The whole Zoom, telehealth push, because now many of these areas that did not have specialized services like before, Avinash, now actually it's becoming available. So this has been such a boon for us. I can connect with my patients who cannot travel because they have arthritis, but they have cognitive impairment. We can provide extremely good care by coordinating the care with we have a team called the Behavior Supports Ontario. These are trained in dementia. I can actually get these staff to connect with them to do cognitive enhancement, cognitive retraining. So we haven't really had a problem from that point. So this is the plus point. The problem has been a number of different areas. The first is many families, because of the difficulties with the pandemic, were bringing families and dumping them on the doorstep of the emergency rooms that they can no longer handle their family members. The second problem we had is it became clear that many people did not have insurance. So as much as I can speak to them at their homes, they didn't have insurance to cover the medications. So it became a bit of a problem when you're looking at medications like memantine, which were not covered in Canada. So it became very difficult in terms of being able to provide specialized services when they really didn't have insurance cover. And this came to the fore because of the pandemic. Then obviously, as elderly individuals being admitted, family members not able to visit, confusion, needing reorientations to families to call in. Plus side, we've tried to use more of technology for them to keep in touch with their loved ones. I won't take much time, Avinash. I know there's others who will share their
Yes,
opinions.
sure. Dr. Sujoy, on similar lines, I mean, UK and Canada have some differences in the healthcare system, but what would you like to tell us about, the challenges faced or the ethical angle with dementia care, the challenges faced in the UK?
Yeah. So again, many thanks, Avinash, for inviting me, and I'm really, privileged to be in such an esteemed panel. And I think the topic is very, very important for various aspects of it. Now, in terms of your question, one thing in the UK, obviously UK is much smaller compared to Canada. In terms of old age psychiatry, UK has quite a heritage, actually. I mean, it is one of the countries which developed old age psychiatry very early, 60s and 70s, it started developing. It's got a very well organized system. And what we have seen a shift in terms of obviously more and more community-based care. So inpatient beds went down, community services have developed, and I think there are fairly well-developed community services. Obviously, a big challenge is sort of end of life or long-term care in terms of nursing homes and things like that. As you said, for the time, I'm not going into talk about the details of the UK structure, which is different from Canada, particularly in terms of because the NHS is always free at the point of delivery, and it's not an insurance-based service. It's blanketly funded by the government. So it's very different. But whereas a social care in UK is a different challenge because there's what we call means testing. So certain people have to pay for social care, certain people don't, and that creates a dichotomous, and that is currently a huge political issue which has been ongoing. In terms of ethical challenges in the UK, I would say, going back to the four sort of pillars of medical ethics, of beneficence, non-maleficence, and autonomy and justice. I would say the two key areas, one is autonomy. UK has developed a very, I would say, well, comprehensive Mental Capacity Act, which obviously in a sort of bread and butter of practice in terms of dementia, but it still poses huge challenges. And this balancing between autonomy, patients' rights and patients' autonomy versus your duty of care, and how you balance that in relation to risk management is a minefield. And I think that's a very big challenge for us on day-to-day practice. The other bit is in terms of justice, the equitable distribution, because like every other country, UK is facing a huge cost in terms of healthcare. And there is a lot of question that are elderly being discriminated. And that became very open in terms of the pandemic. When you have limited resource, do you actually try to save certain people and you don't other people? And also the quality of care in the nursing care, long-term care, end-of-life care, all these are ethical challenges in our practice. So from my point of view, these are probably the two areas where we face biggest ethical challenges in our day-to-day practice in the UK.
Right. Dr. Russell de Sousa, sir, the question for you is, as someone who's been working so extensively in the field of ethics, what are the ethical challenges that you think COVID-19, has posed for, dementia care?
Thank you, Avinash and Vidya for inviting me, and thank my colleagues also for joining us here. Well, this is very important. COVID, as we heard from Shabir and Dr. Sudhe, I think the main issue, big issue that we've faced, and again, just to give you a background, Australia is very much like it's very much like UK, and at the same time, like Canada, it's very, very big, very large, and so we have a fairly good community system. We had, and again, it's universal, so health, all that is looked after. But then, when it comes to distances, again, in regional and outback places, you have the same problems that Dr. Shabir had mentioned. But of course, now with telemedicine, this is much better. And more recently, there has been a Royal Commission on looking at this, and they've come out with a whole lot of issues that came up. Now, this is not related to COVID. This is related to looking after the aged in the nursing homes and so forth. And a lot of issues have come out, virtually turning the whole system almost, they wanted to almost turn it upside down. A lot of abuse and things like that have come out, which are pretty much to do with ethics. Now, with COVID, one of the main issues that we have faced is, as Shabir and others noted, that the social interaction, families and others have suddenly had to be separated. So you have someone in the nursing home, but no one can go and see them. And so this has led to a lot of issues, even them getting sick and even dying. They have not been able to have their family and others next to them. And that's one of the, I think, the major issue that's affecting, and to make matters worse, Melbourne, where I am, last year in the beginning of this the pandemic, we had a quarantine failure, which ended up pretty much in the nursing homes or the aged. So we had a large number of mortality death due to the COVID in this few of hundreds, because the infection spread to the that was when COVID had started. So people who caregivers in the nursing home, their partners were working, doing security or so, looking after the the quarantine people who are coming back, returning from other countries, and that led to a whole set of infection and dying. So that was the main from the COVID. You asked me about COVID.
Correct. From the COVID.
Yeah. But from all the other parts, the same issues are there with autonomy, balancing, and again, the interest of families and others, balancing the family's interest and the individuals, what they would like to do and so forth continues to be the issue.
Right. Well, Vidya ma'am, you run a daycare center in the city of Mumbai, and I mean, what do you think are the main, challenges that you all face? Maybe not ethically, but when it comes to managing a daycare in a busy center like Bombay, in a busy city like Mumbai. I mean, what are the major challenges you face?
Thanks, Avinash, for asking this question, before which I thank Dr. Russell, Dr. Shabir, Dr. Sujoy, joining in this program, and of course, Avinash for moderating, which he's excellent at, and he does it very easily and flawlessly, and puts everybody at ease. So coming back to the daycare center, I think COVID has affected, you're asking regarding COVID, right?
Yeah, I mean, the challenges of, a daycare during COVID, particularly.
Yeah,
yes. Okay. Yeah.
See, the thing is that COVID affected everyone and it came unannounced. So nobody was really prepared. To add fuel to the fire, there were a lot of family members who were kind of caregivers to the person living with dementia who had developed a COVID. So there was another separation from that person with the person living with dementia. Also, what we found is that we had suspended our services temporarily, a week before the official protocol came in, just for the thing that, they're more vulnerable to the disease because of other comorbidities. But what I found was a lot of them came back saying that my son's lost his job, he's not going to work, he's at home, he can't afford to pay school fees, and the children can't. That's why the children are at home. And you cannot explain to them. So the only thing I had a standard reply, which of course they'd forget the next moment, but at least it pacified them, saying that the building is getting repaired. Because repair building is something that they understand. You can't rationalize with them. So it was very difficult. Second is that I found the families and the members living with dementia being closeted for too long, which had never happened in the past. So each one was breathing down each other's neck. So, I found that there was a lot of abuse. In fact, I was reading into a lot of papers, and I was shocked to find that cultural countries, countries that have a cultural background also had, including India, also had a lot of family abuse. And the first was the direct member, like the son or the daughter-in-law. And it was horrendous, So that is another thing. Third is that members with dementia missed coming to the center. So initially, for the first 6 years, they couldn't focus. They didn't know what a phone was. So I saw the positive side that they learned to know what a phone is. They learned to focus with the laptop or the, regular computer. So in that sense, COVID was quite positive because they learned to sit in a place for long, actually relate. Initially, we had them coming too close to the phone, to the screen to kiss us because they thought we were there. But they did fine. We had... so that they wouldn't be very onerous to the family member or the caregiver. We had a lot of goodie bags go, some things to eat which they liked and they were allowed to because of their health issues, and plus craft materials. So that was going, and we kept them busy. We continued the person-centered services even through the COVID, which we still do now. And we've started home care now from October last year.
Right. Shabir, so my question to you is that we in India, particularly, all dementia care services are paid for by the patient, and so many patients are reluctant to use hospital care or use specialized dementia rehabilitation care because they don't have insurance, and the focus is more on home-based care. Do you think because of probably healthcare services being provided by the government, it's the use of hospital-based care or center-based care for dementia is more in Canada? And do you think, I mean, that poses certain, I mean, challenges at times?
Yeah, that's an excellent question, Avinash. You should be in policy making. You see, one of the fundamental problems we face, and this is actually not restricted to Canada, and I can tell you because I've done this work in so many places. There's a very strong, within quotes, geopolitical angle to it. Because on the one hand, people do want these people to have access to care. I mean, who doesn't want your people to have good healthcare? Nobody. The problem is the cost is not just huge, but that even, and again, this is going to sound very political, even wealthy people don't want to pay for healthcare. They'll go buy a bottle of liquor, but they don't want to buy the antibiotic, right? They will go and go take a trip for thousands of rupees, but they do not want to pay for an ECG. It's a very interesting concept, but I find this more common in India versus in Britain. I find people are willing to pay to some extent for the healthcare services to some extent. But even there, Sujay will tell you, there are people who will say, no, I should get free healthcare. And then the whole thing about, health tourism became an issue. And then NHS started getting, there were lots of very interesting variations to it. In Canada, I think we do have a fairly good mix in some ways. The first is there is a big push with government-supported moves towards providing these traditionally hospital-based services in the community. So they started what's called Behavior Supports Ontario in Ontario. And this is very unique to Ontario, although other provinces also have, to some extent, similar mechanisms, but I find it better developed in Ontario. We are the largest province in terms of population.
Right.
What happens now is when patients come to access this care, they have two big problems. The first, Avinash, is even if it's free at the point of contact, we don't have an environment to give it in. You can't just provide it in any hall. You need certain facilities to be there. We don't have that. Second thing in Canada is transportation. We do not have good public transport. So unlike in India, bus or get auto rickshaw, Canada transport is very expensive. So if you can't drive, and most people above 85 cannot drive, then you can't even go to that common location, however close it is to your home.
Right. Dr. Sujoy, I mean, what are your thoughts? Do you think in UK there's more of a push towards what we call hospital-based care against home-based care, or
No, actually, hospital-based in UK, there has been a depletion of hospital beds for over the last couple of decades, in a massive depletion of hospital beds. And there's a huge push to provide care in the community. I'll give you an example. Like when I was a trainee here, we used to have only the district where I work in West London. We used to have 3 inpatient units. Now we have 1 inpatient unit for 3 neighboring districts. So that is the number of beds that has gone down. To compensate that, we have got obviously the community-based teams, but older people service now split between memory services, and they vary between places, and there are different resources. But also there is a sort of what you call urgent care teams, crisis teams for elderly, which are developing, which kind of complement the usual multidisciplinary community teams. And then you have got day centers, particularly for dementia. Day hospital for functional mental illness used to be there, they're all completely gone. Now these day centers are primarily funded by local authorities, and there has been a massive cut. So like, for example, in our district, we used to have 2 day centers, now we are down to 1. So it's still providing a very valuable service, but the problem is it depends on which part of the district or the borough you live. You might end up, being picked up 8 o'clock in the morning, and then it's taking you an hour through morning traffic to get to your day center, which can be challenging for somebody 85-year-old. So that's where the resource is pushing. The other thing in UK, which is developing now, the government, just published their new 5-year forward plan. And what they're looking into more and more integrated care models, particularly for elderly. So people who have chronic medical problems, they're trying to bring in medical care along with mental health care and dementia care. So, most of the elderly have comorbidities. They have diabetes, heart problem, and various other things. So they're hoping that rather than the multiplicity of teams being involved with their care, can they coordinate? But obviously, it is easier said than done. And that's the big challenge. And it might actually, over coming years, might change a lot the way we practice and we provide service. Because our service mostly are, community-based. We have a clinic-based and home visits and things like that. But we might be more aligned to primary care and things like that over coming years. So that's how the things are done. But in UK, one other thing, I'm sure it is probably shared in other places, is we have quite a well-developed voluntary sector. And though they are funded partly by the government through the local authority, but they're partly, funded by public gifts and donations. And some of these voluntary organizations, say, for example, Alzheimer's Society is quite big. And many of them run parallel services in terms of day center, home care, home help, call-in care, those kind of things. And that complements the mainstream services to some extent. But they are also squeezed in terms of the demand. We are an aging population and the demand keeps on growing. And I think the other thing what is missing in the UK in terms of integrated care is that psychiatry, neurology, geriatrics are very sort of siloed, separated. We don't have them together, which you sometimes find like, in Canada or mainland Europe. You find they're much more aligned than in the UK. And I think that is one barrier of giving the best possible care to people.
Right. So what are your views about the home-based versus hospital-based care scenario in Australia? What do you feel, Dr. Russell?
Well, as I said, here in Australia, I mean, like he was just saying, you have a good community care, but more recently, the issue has been going into the nursing homes, that's been a bit of a difficulty, and now they are funding. There are a lot of funding to keep you at home with support services. So they've actually privatized these their companies now, and you've got each one is assessed. Depending, as he said, the comorbidities, both mental or physical, and they've looked at funding. They work out funding, and now and this is very interesting because this in the last few years, this has happened where the family or the member can actually buy the services. The whatever service, they have companies that are actually giving providing all the so including social workers and including some rehab and so forth. So they actually are now coming to the wanting your business or wanting, so the patient has got the ability to choose, or the family choose who they want to offer this home care support services. So that's a new thing in the last few years that has come out, and I think that's certainly made it better. But again, in a country like this, it's okay in the metropolitan areas, but once we go into the rural and regional areas, it becomes all these become much less, and you can't, you don't have this, even you don't have the company willing to come out and do the home support and so forth. So those are the tyranny of distance is one, and then the lack of, so there's sort of, it's not uniform. That's the issue, but certainly we have good, fairly good community support work. There's also volunteers, as Sujay said here too. There's which are supported by the partly supported, and so they also take a role there. But overall, I think this keeping people in the community in their own environment with the supporting them, that's become the way it's going. And here again, there is an issue there's a change in terms of for getting into a nursing home, you get assessed by the geriatric team or the psychogeriatric team, and because there's funding, and to go into a nursing home, there's a significant amount of funding, and now that's means tested. So if you're not on a pension, or if you're a self-funded pension or what they have here, then it becomes a little difficult in terms of the cost and so forth. So yeah, that's changes that have come in here. But overall, yes, it's still the problem is between the remote, the rural and or regional. We call it regional and the metropolitan. There is significant differences in availability of services and also programs.
Sure. I'm now going to ask you all about, some specific ethical issues. So the questions won't be posed to all members of the panel. Well, Vidya, madam, I mean, what role, do you think? I mean, very often people have asked me this: how can you have spiritual interventions in patients with dementia? Because particularly, they do not have the cognition probably to understand spiritual intervention. So do you think it's ethically right to introduce spiritual interventions to patients with dementia?
See, thanks, Avinash. I think personally, anything that helps anyone for the better is good enough. All of us have in the past, in some form of another, believed in spiritual practice, maybe actively or passionately, maybe in the form of doing work for the community, not necessarily religious practice. But I think spiritual practice does have an impact on the psychosocial well-being of the person. And it also leads a better quality of life from what I hear from the members of the family who come to pick them up. We've had people, some of them refusing to participate. We let them be, but over a period of 5 to 6 months, it has helped them. And they in fact start, saying, okay, come on, let us do so, But in the center, what we've done is that before having food, there is prayer. So obviously that is inculcated in them, not only just for spiritual practice, but not to waste food. And believe me, sometimes I think that they're much sharper at certain times when we aren't. So I don't know whether, their brain functions just right enough for them at their age. But personally, I feel it does help a lot. Where yoga is concerned, it's only in early dementia, early diagnosis of dementia that it helps, but it certainly helps for the physical aspect. And I guess they become much calmer also, whether they're actively or passively listening.
Right. Shabir sir, my question to you is that, there's so much of a buzz around the use of, robotics, electronics when it comes to dementia care in the current scenario. One of the things which people have marketed here in India, and I'm sure it's available abroad, is that, you tie a wrist band to the dementia patient, whereby if he has a tendency to wander off, I mean, you immediately get a beep on your phone. The relative gets a beep on the phone that, he's wandered out of the house or within a certain perimeter. Do you think it's ethical to sort of electronically, gate them? I mean, because a lot of people say that they're not animals, that you gate them or whatever. That's one thought. The other thought is it's a highly protective device. So what would be your views, on this?
We're presenting actually on this in the coming scientific decision. It's called Newer Technologies in Dementia. It's very interesting, Avinash, because the very same person, for example, if you had not put the Wander bracelet and they went outside and were killed in a car accident, would you be charged with, being neglectful? So the point is, we often have this notion that we need to get the right balance. And, Sujay interestingly spoke about the whole notion of autonomy and non-maleficence and things like that. Dementia is currently taking center stage. And I published a paper with Minna Chandra. Minna did a wonderful paper. We were looking at ethical issues in research in dementia. So whether it's Adunama cab, whether it's to use newer technologies, for as long as we recognize that we have followed due process, does the person have capacity? Is he able to understand what it is that's going on? Once you lack capacity on that advanced stage of dementia, the only thing you can do is keep the person safe and comfortable. The whole notion of choice and being able to discriminate becomes very difficult, as much as we feel bad about it, because if you're your parent and you want them to have the right quality of life, safety becomes a fundamental issue. So from the ethical point of view, I think for as long as we follow certain parameters, we should be okay with using wander bracelets.
All right. So Joy sir, one of the things that I want to ask you, since we're talking about ethical issues, um, in centers in the UK where patients with dementia do come in and they may get aggressive or violent, what is their policy with regard to restraining such patients?
That's the most sort of relevant question. And, this is a major challenge in dementia care, and particularly people getting aggressive, not only in the centers, but in their own home. And this is commonest when the people are given personal care. Obviously, the sort of innate reflexes, they will be fighting, kicking, punching, and this is a problem in the nursing home as well. I think the framework is very similar to what Sabir has described in relation to the GPS bracelets. Basically, it all goes down to capacity, because what we are trying to do, we are trying to balance between autonomy and duty of care. So in UK, we have the Mental Capacity Act, which came into place in 2005. And essentially, it says that in a situation like this, you have to do a mental capacity assessment. And there are 4 elements to it. The person need to understand, the person need to retain the information for the purpose of the assessment, need to weigh and balance the pros and cons, and able to give you their view and explain why that view is. If they fail in any of these legs, then it's deemed they don't have capacity. But what we need to understand is capacity is task specific. So they don't have capacity for that particular element of care, but they may have capacity on other things. Now, once we establish somebody does not have capacity, then the legislation asks us to follow a certain steps, what we call best interest decision making. And the best interest decision making, the elements into it is, one is the medical medical opinion, what we think, and obviously the opinion from the carers or nurses who is actually caring for the person. But we also involve the next of kin or the family in this decision making. And then if we have to use either restraint or medication or both, then we discuss the pros and cons. And kind of within the Mental Capacity Act, the families become the surrogate decision maker. And often you will find that the families would agree. If we disagree on something, then at the end, the family need to understand that if we cannot control some of those behaviors, that have consequences by itself. So for example, the care home might say, we are not able to care for this person, and then they lose their place. Or similarly, there is a danger that person might be hurt or somebody else might be hurt. So usually when you follow these procedures, that's how we resolve. So we do use physical restraint. Now, the law also says that it has to be proportionate. And in UK, we have a very strong, what you call a safeguarding procedure. So that means, every time this kind of restraint, particularly if it ends up in a bruising or something like that, that has to be recorded as an incident, and that has to be reviewed and sort of scrutinized. So that's why, because just because you are allowed to do restraint doesn't give you any authority to do bad care.
Right.
So that's
Right.
how we differentiate between proportionateness vis-a-vis abuse. So that's
Right.
how we go about it.
Sure. Thank you, sir. Dr. Russell, this is one of the toughest questions, and it's for you because you're one of our senior ethicists in this group. There are some countries in the world that have legalized euthanasia, and there are some countries that haven't. And if as an ethicist, not with any, I'm not looking at the legal angle here, but if relatives come to you and say that I have a father who's 85 and he's bedridden for the past 3 or 4 years and has dementia, he doesn't even know himself, leave alone know us, and we would like to sort of consider euthanasia for him. What would be your take from an ethical angle?
Well, as you know, I do talk about the critiquing the ethics of euthanasia, because the ethics of it, Peter Singer, and again, there are different views to this, but there's one view of loss of personhood. Okay, this is the way you bring the, the passive euthanasia, and the ethics talks about loss of personhood. When someone loses their personhood, then there could be, it's okay if they are euthanized, okay? But the question is, there's a criticism to that, in that loss of personhood does not necessarily mean you've lost biologically. So the issue here, there's two parts. There's an ethical issue, and of course, there's also the legal issue. But since Avinash has asked me particularly about from the ethical perspective, this is certainly the question that we talk about loss of personhood as an ethical being one of the reasons that you can offer passive euthanasia or for that matter even active euthanasia or assisted dying, as it were. But from again from an ethical perspective, it's I don't see that as although you might say it's a quality of life. And so what is quality? So who makes which, who is able to tell us which quality is good, and up to at what point does quality become bad, and at what point does it become good? So these are some of the issues that come up there. And the next issue is the question of autonomy. When you're talking about someone lost their function, their cognitive function. But what about from the perspective of your autonomy? Where does autonomy end when you say, don't want to live, I want to be, for whatever pain or whatever reason, I want to end my life, and I'm asking for assisted suicide. So again, the same issue comes up. How do we, is there a limit to autonomy? Where does autonomy stop?
Right, sir. Right. Thank you so much. Vidya ma'am, my question to you is a very Indian one, and that's that very often, you may have patients who want to come to your daycare, but you may at the same time have relatives who don't want to spend for them. So, and well, the patient wants to come to you 6 days a week, but the relative tries to tell you, we'll send him 3 days a week. Now in such case, I mean, is it ethically, now there are financial angles obviously, because not that you would charge exorbitantly, but you have charges because you have a place to run. The relative has to worry because he's looking after his father, he's looking after his children, he's looking after his wife, he's looking after his mother, so he also has to fit everything into his salary. So the whole issue here is that, then what is ethically wrong there? I mean, is the relative wrong? Is the patient wrong to demand? I mean, I know I'm playing devil's advocate here with every one of you all, but I mean, I'm just trying to get all the ethical issues in.
See, firstly, I think each situation is different. You have to take a very balanced view, keeping in mind the financial status of the family, the state
Ma'am,
in
one
which
minute,
the
1 minute.
person.
I will come back to you. Dr. Shabir Amanullah may have to leave us because he has a patient to see. So I'm just going to ask him one question and then I'll come back to you, sir. My question to you, before you can go off, is there is so much of new research happening in dementia care, and some of the areas which are being looked into are newer drugs for dementia, and of course stem cells in between were being tried. Now particularly many of our dementia patients really can't decide on their own whether to enroll for a trial or not. So what are the we know that there's a legally acceptable representative who decides for them. So how do we decide whether that LAR or that legally acceptable representative is deciding correctly or not for such a patient?
Excellent question. And this is why I don't know how many of you know Minna Chandra. Minna, we had published this paper with Vijay Herbishetter as well in the Indian Journal of the editor is Shahul. We addressed this issue specifically because we had a discussion about ethics, and Russell had put the seed in my mind. And this is going back as the pandemic started. And Russell said, Shabir, I fear that people are going to use the pandemic as a reason to want to do new initiatives. There's a lot of foresight that Russell had. So what we were concerned about is many a times relatives can be incentivized. It becomes very easy, especially when you're in poverty.
True.
There is really no fine answer, because I know even in the West, the drug companies are very wealthy. They invite you for a meeting and you're in the Bahamas, and the money plays a big part. So in terms of where we draw the lines, my feeling is we have to start somewhere. And the key issue is for the researcher to have learned what bioethics is all about, to convince himself or herself that even if the relative is agreeing to it, I will spend some time with the patient to make my own decisions as to whether there's a level of competence or is there a risk of abuse in this context. That's
Correct.
really because it's very complicated.
Right. Thank you. So if you have to leave, please sign off. I mean, we can totally understand that, you are engaged, you're on call today, but thank you so much for being there. Yeah.
Absolutely right.
Yes,
And as
sure.
usual, you're an amazing moderator. Take care.
Thank
Thank
you.
you,
Thank you.
everybody.
Thank you so much. Yeah. Yes, Vidya ma'am, coming back to you. Suppose, as I said, if the patient wants to come 6 days a week, but the relative says I can afford only 3 days. The relative is right where he's coming from. The patient is right where he's coming from. So, how do we sort of morally handle that situation?
See, I would like to say that I like to sleep well at night without a tablet down my throat.
Correct.
I would see each case differently. We have had cases where we have come down on the price, but we have not done it at the cost of the person living with dementia. Okay? Because if they cannot afford for 6 days a week and they can afford only for 3, we do that. And, like we've had times where we had to do this, and in time there's been some very challenging for the family to look after the person 6 days a week, 24 hours. So it's just case to case basis, and we have been very flexible in doing what we have, but we rest well with a conscience and sleep well too. So each case is taken as it is.
Right. So Joy sir, which is going to be my last question, I mean, for you, and then moving on to Dr. Russell, and then we'll have the last word from the three of you all. One is that with the advent of, so much of work being done in geriatric psychiatry, and a lot of people ask me, I mean, do you think, there are patients who come to us and say, see, we're traveling abroad, and we have a long flight, and we're a little worried that the patient with dementia may create a ruckus on the flight. So could you prescribe something maybe 2 hours before the flight so that he's sedated on the flight, and then once we land, things will be fine? So is it ethically to do that? This is a very common clinical scenario that we face.
Yeah, that's a very, very good question. Actually, we looked into it in a few years ago a bit more systematically, and there are multiple issues in terms of traveling, particularly if you're going long haul. The first issue is about the airport. The airports are not necessarily a dementia-friendly place. You have long queues, a lot of people. It can be extremely stimulating to the dementia patient, and going through the security and things like that, people can get very agitated. Also, whether they're able to access the loo and things like that. The second issue is on board. There are two issues. One is, despite of the cabin pressure being maintained, actually the oxygen saturation is lower than normal. So that can cause a degree of cerebral hypoxia, and that can itself cause problem. The other problem is obviously the planes are quite a confined space, and going to the toilet, if particularly, I mean, now with COVID, it's even more problematic because the masks and how you are being controlled. So that is another risk of people getting agitated. The third issue is about the difference in time zone, because the difference in time zone itself might be very disorientating, particularly say if you're traveling from say India to US. It's a very long flight, and then you might have a massive difference in the so there are multiple factors in terms of which can affect the person adversely. Now, again, going back to the issue of capacity, if the patient does have capacity, you see, one of the things Mental Capacity Act says that people are entitled to do, within quotes, unwise things. They can make unwise decisions. As long as we are capacitors, in our life, we often make unwise decisions. But that doesn't mean others will make decisions for us. So I think the important issue is to explain the patient all these issues and difficulties that they may face. If the patient does not have capacity and it's the family who wants, then really we need to understand what is the purpose of it. And sometimes, they might say, well, my dad wants to, maybe other part of the family somewhere else. My dad wants to meet them. This is all his, all the life he wanted it. And, okay, we understand there's a bit of a risk, but we probably take it. Again, the decision has to be individualized. But I think it's very important they need to be explained all the risk issues involved, what to face, and then you might be able to, prescribe if you think that is the right decision in the patient's best interest. That's the best I
Right.
can say. I don't think there is a blanket
Correct.
policy we can
Right.
apply.
Right. So my last question to you, Professor Russell de Souza, for today is that when it comes to patients with dementia per se, I mean, can it happen that uh, we've always had relatives who might be out to say get their property, get many other things, and in such scenarios, I mean, do we like keep a very neutral stance, or do we advocate for the patient? Because we know, I mean, sometimes talking to the relative that this man is probably just here so that he can get the patient certified and get hold of his property. But at the same time, on assessment, yes, the patient does have dementia. So when they ask for a certificate, I can't write that he does not have dementia. So where does that put the physician in an ethical standpoint?
Well, to put it in perspective, are you saying that the patient has got dementia, and you feel that the family or other
Yes.
significant other is in some ways wanting to use from a financial perspective? Is that what you're
Yes.
saying?
Yes. Yes.
Well, yes. Now this, and I think Sujay, I don't know how it is there, but here you have a legal and a moral responsibility to safeguard your patient. And in Australia, you can put an application for the guardianship and the administration board. So not just the doctor, but even the what do you call it? The caregiver or anyone looking after can choose to make an application to the administration board. So they will then ask. They will be either the person who will have to prove or to go to the tribunal, and they will decide if that person is fit or not fit. If not, the trustee becomes the board itself will take over the financial administration. We have many patients like that where you have the state trustee becomes the administrator. So we have not only an ethical and moral requirement, but also a legal and professional requirement to protect the interest of the patient, that certainly is the way I'd see it.
Right. Well, before we end today's panel, I mean, I would ask all three of you to probably, I mean, Dementia Awareness Month is September. We're talking on ethical issues in dementia. So your 2-sentence takeaway message for people, starting with you, Vidya ma'am.
I just like to say, one person at a time, with a head on your shoulders, with a conscience clear, make a decision never to look back, that you had gone amiss, and if you did, you had done your best at that point time T. And remember
Right.
those who cannot remember.
Right. Sujoy, sir.
I think what we need to understand that dementia is not just about memory. It's a complex neuropsychiatric problem which has got multiple dimensions, both medical, social, psychological, individual. So every patient, we need to understand the person. We need to understand their abilities. At the same time, we need to understand their, what their needs are. It is a dynamic process. It changes over time, and our support to the person has to change. And at the middle, we have to think of the person. So truly a person-centered care. That's what would be best for a
All
person
right.
living with dementia.
Russell, sir, your final words before we sign off.
All right, it's been a very interesting program today. I'd like to end saying a key principle is to understand and remember that people with dementia remain the same equally valued people throughout the course of the illness, regardless of the extent of the changes in their mental abilities. That's something I'd like to end asking all to remember that.
Well, thank you, sir. Well, thank you, everyone. And it's been a very amazing panel. Thank you so much for being with us. I mean, Dr. Russell, particularly being there at an odd hour. Of course, Sujoy sir, also the afternoon on a Sunday afternoon, where you could actually be with your family or with us. I mean, we're very thankful for that, Vidya ma'am. And with that, we'll sign off for today. Good evening and God bless all of you. Thank you
And
so
thank
much.
you so
Same
much.
to you.
And thank
Same
you
to
all
Yes,
you.
for
yes,
taking part
yes,
in this,
yes,
all
yes.
the colleagues here. Thank
Yes.
you very much.